So coming to refeeding syndrome, very, very high potential question, must know question. So refeeding syndrome is defined as a medical complication that results from fluid and electrolyte shifts as a result of aggressive nutritional rehabilitation from any source. It can be an oral diet, enteral nutrition, parenteral nutrition, or intravenous dextrose solutions. So even in dextrose solutions, you can get refeeding syndrome. Metabolic disturbances manifest as cardiopulmonary, hematological, and neurological dysfunction in these subset of patients. And hypophosphatemia is considered as the hallmark of refeeding syndrome and is often used as a surrogate marker for refeeding syndrome. So the American Society for Parenteral and Enteral Nutrition, ASPEN 2020, they define it as a decrease in serum phosphate, potassium, and magnesium within 5 days of starting feeds, or significantly increasing nutritional support in a previously malnourished or starved patients. So they have a grading, mild, moderate, and severe, where mild is 10 to 20% fall in any of the electrolytes, moderate is 20 to 30% fall, and severe is more than 30% fall. Or there is presence of organ dysfunction due to electrolyte shifts and or thiamine deficiency. So this is a very important definition that you need to keep in mind. So the risk factors, we have high risk factors like BMI less than 16, more than 15% weight loss in 3 to 6 months, no intake for more than 10 days, or low baseline electrolytes. Then you have very high risk factors like BMI less than 14 or no intake more than 15 days. And ICU specific amplifiers like organ failures, sepsis, mechanical ventilation, alcohol use, oncological patients, diuretics, insulin therapy, CRRT, and frailty. Frailty meaning the elderly group of populations who are the ones who are at increased risk of refeeding syndrome. So these are the important risk factors that need to be kept in mind. From an exam perspective, when you read so much of content for theory, it is difficult to remember. Please remember at least 3 of these. So coming to the pathogenesis, first you need to know what happens during starvation and then what happens during refeeding. So the metabolic changes during starvation is, under normal circumstances, the primary fuel of the body consists of glucose that is derived from carbohydrate breakdown. So at least 100 to 150 grams of glucose is needed for daily optimal brain function and to prevent protein breakdown. So excess carbohydrates and protein intake can be stored as fat. So during short periods of fasting up to 24 hours, glucose which is stored in liver and muscles can be utilized after glycogenolysis to provide carbohydrates. During prolonged fasting, the metabolism switches from fat and protein utilization after glycogen stores have been depleted. So glucose is produced via gluconeogenesis, that is by degradation of amino acids, fatty acids, lactate, and pyruvate. So when the fasting period prolongs, the metabolic rate decreases by 20 to 25%, plus there is concomitantly depletion of your intracellular electrolytes and vitamins. So these loss are further exacerbated by diarrhea, vomiting, diuretic use, and other additional losses. So what happens during refeeding? So the patient is already starved. There is intracellular depletion of electrolytes and vitamins. So when a patient is reinitiated on a refeeding program, metabolism switches back from the protein and fat metabolism to the breakdown of carbohydrates. This leads in a marked increase in insulin secretion, leading not only to an increase in intracellular glucose uptake, but also an intake of electrolytes such as potassium, phosphorus, and magnesium. So this shift, along with the already depleted glycogen stores, can lead to changes in cardiac arrhythmias, neuromuscular dysfunction, and hematopoietic dysfunction. Insulin causes natriuretic effects on the renal tubules, so that leads to increased sodium and water reabsorption and retention, leading to extracellular volume expansion and In susceptible set of patients, it can lead to severe pulmonary peripheral edema, and if very, very severe, can lead on to acute heart failure. So the clinical manifestations are usually seen within 2 to 3 days of refeeding. So they can manifest as hypophosphatemia. So from an exam perspective, you can classify it into 4 areas: neurological, CVS, RS, and hematological. So in neurological, there can be paresthesias, weakness, delirium, seizures, and coma. CVS, there can be shock because of decrease in contractility, causing a decrease in stroke volume. Then there can be cardiac arrhythmias. There can be diaphragmatic weakness. Then hemolysis, thrombocytopenia, and leukocyte dysfunction can also occur just because of hypophosphatemia. With regard to hypokalemia, there can be weakness, cardiac arrhythmias, gastroparesis, paralytic ileus, or colonic pseudo-obstruction can occur. So that can manifest as nausea, vomiting, abdominal distension, and constipation. And in worst case scenarios, it can cause rhabdomyolysis. Hypomagnesemia can produce symptoms which can be a combination of hypokalemia and hypocalcemia, whereby there can be weakness, tremors, altered mental status, tetany, seizures, and coma. Cardiac arrhythmias can be seen in these groups, and they can also lead to ileus, which can manifest as nausea, vomiting, distension, and constipation. Then thiamine deficiency can occur, which can manifest as lactic acidosis, Wernicke's encephalopathy, Korsakoff psychosis, wet beriberi manifesting as heart failure, nystagmus, and dry beriberi manifesting as peripheral neuropathy. Then sodium retention, which can lead to fluid overload, pulmonary edema, and cardiac decompensation in susceptible group of patients. So the diagnostic criteria, like I said in the initial slide, it occurs within 5 days of reintroducing or significantly increasing the calories. So the severity can be classified as mild, moderate, and severe. So mild is 10 to 20% fall in serum phosphorus, potassium, and magnesium. Moderate is 20 to 30% fall, and severe is more than 30%. The hallmark is hypophosphatemia, though hypokalemia and hypomagnesemia are equally important to be looked into. So coming to the treatment. So identification of critically ill patients at risk of refeeding syndrome is very, very important. So you see there is a decrease in phosphorus level of at least 0.5 milligrams per deciliter to below 2 milligrams per deciliter from the baseline levels on ICU admission within 72 hours after commencement of nutritional support is very, very high suggestive of refeeding syndrome. And important to assess for risk factors. Like I said, you have high risk factors, very high risk factors, and ICU related factors. So the initial management, the initial treatment, you can classify it into two parts. That is the general measures and the specific measures. So in general measures, you have airway management, where if it is compromised, you will have to intubate. And ventilatory management, you can go with NIV or invasive ventilation if there is respiratory distress, apnea, or bradypnea. Then circulatory management is mainly you need to concentrate on management of heart failure and cardiac arrhythmias. So cardiac arrhythmias can be managed with pharmacological and or electrical cardioversion, and acute heart failure can be managed with inotrope supports, vasopressors, and or diuretics. And with regard to disability, if they present with coma, you need to rule out other causes like structural lesions and other metabolic abnormalities before you come to a diagnosis of refeeding syndrome related complications. And if seizures are there, then you will have to initiate them on anti-seizure medications. So with regard to specific treatment measures, before feeding, you check phosphorus, potassium, magnesium, you correct them if they are low. Administer thiamine of 100 to 200 milligrams IV before starting feeds or IV dextrose, and continue it for 5 to 7 days. And supplement multivitamins, that other vitamins, for at least a period of 10 days in this subgroup of patients. With regard to caloric initiation, start with 10 to 20 kilocalories per kg per day or 100 to 150 grams dextrose in the first 24 hours. So you advance by about 25% of the goal in every 1 to 2 days. If the electrolytes is very severely low post initiation, then delay the feeding till it is corrected. If the electrolyte fall occurs rapidly during feeds, then you reduce the caloric content by 25%, stabilize, and then re-advance slowly. The best way of explaining this is through this diagram. So on day one, you start at 25%. Then on day two, you increase it to 50%. Day three, you increase it to 75, and day four, you try to get it to 100%. So you assess the daily phosphorus levels and you then see how severe the fall is. So if there is about a zero point 0.5 to 2 milligram per deciliter fall, then it's something that you need to be concerned about. So if it is very severe and you see that the other electrolytes are also very markedly low, then you need to reduce it by 25%. All right. So usually for a 50 kg patient, you would start with 10 kilocalories per kg per day as a target. So you go with 10 into 50 is 500 kilocalories on day one and gradually increase. So this table is being taken from the ESPN guidelines. So this advancement of 25% is based on the ESPN. It is preferable from an exam perspective to go based on the ESPN guidelines for this because the Aspen recommends it as 33%, but it is very, very difficult to titrate the feeds forward and backward based on the Aspen guidelines. So what I would personally recommend is to go with the ESPN guidelines of management of feed initiation and titration. Then with regard to electrolyte management, like I said, you need to monitor the phosphate, potassium, and magnesium levels every 12 hours for the first 3 days. Repeat according to the standard ICU protocols. So what they generally say is to potassium levels should be like supplemented as 2 to 4 milliequivalents per kg per day, phosphorus as 0.9 to 1.8 milliequivalents per kg per day, and magnesium of 0.4 milliequivalents per kg per day IV or 0.8 milliequivalents per kg per day oral. So this is as per the Aspen guidelines. So you continue daily monitoring till the patient is clinically stable from a lab perspective and clinical perspective. Monitor vital signs every 4 hours for the first 24 hours. Usually in ICU setup, there is continuous telemetry, so this is not really concerning. Cardiac monitoring is essential in severe cases. Strict fluid balance should be kept in mind, and daily weight should be noted if it is feasible, and it is important to monitor the blood glucose levels. So there was one trial in relation to refeeding syndrome. This came way back in 2015. Restricted versus continued standard caloric intake during the management of refeeding syndrome and critically ill adults. So the question was, in critically ill patients with refeeding syndrome, does restricting caloric intake compared to unrestricted caloric feeding reduce the composite outcome of ICU length of stay, overall survival time, and mortality at 60 days? So the final conclusion was there was no significant difference in the primary composite outcome, that is alive and after ICU discharge at day 60, but secondary outcomes like higher survival at 60 days in the restriction group was seen, longer overall survival time, fewer respiratory or airway infections, and shorter hospital stay. So these were the main positive takes from the refeeding trial. So then coming to the next question, that is gut dysbiosis and role of probiotics in ICU. So gut dysbiosis is basically alteration of the intestinal microbiota composition, diversity, and function. So ICU patients are at high risk due to antibiotics, mechanical ventilation, vasopressors, enteral nutrition interruptions, and critically induced immune dysfunction. So dysbiosis is considered as the motor of multi-organ dysfunction syndrome. So the pathophysiology of how this causes a problem is critical illness or ICU factors lead to loss of commensal microbes with a decrease in diversity. So on the contrary, there is an overgrowth of pathogens like Enterococcus, Pseudomonas, and Candida, which leads to increased gut permeability and barrier dysfunction, which leads to gut translocation with endotoxemia, leads to systemic inflammation, sepsis, and MODS. So the normal gut function helps to maintain the gut integrity, barrier integrity. It produces short chain fatty acids like butyrate and acetate, which are the energy for the colonocytes. It helps to balance the immunity via the T helper cells and the regulatory T cells. And colonization index resistance is very, very preserved. That is, it helps to block the pathogens from interfering with their function and proliferating within the gut. The problem is because of the effect of dysbiosis in ICU, there is a barrier leak which leads to endotoxemia. There is loss of short chain fatty acids leads to poor mucosal repair. There is immune dysregulation leading to increased inflammation, and there is a pathogen overgrowth because there is no regulation. So that can lead to Enterococcus, Candida, and MDR bacteria. So the causes for dysbiosis in ICU, broad spectrum antibiotics, which kill the commensals, leading to domination by resistant organisms. Mechanical ventilation, where there is an oropharyngeal flora translocation leading to VAP. Vasopressors and shock, which leads to gut hypoperfusion, leading to ischemic or hypoperfusion injury. Parenteral nutrition, which leads to loss of enteral stimulation, leading to atrophy of mucosa. Opioids, PPIs, and stress, which alter the motility and acid barrier, leading to overgrowth. So these are the important causes of dysbiosis that you need to keep in mind. So the clinical relevance in relation to sepsis, gut translocation fuels bacteremia. So the patient would have come for one problem. Because of this dysbiosis, this gut translocation further adds fuel to the problem. In relation to VAP, migration of gut flora to the oropharynx and lungs is the main mechanism. How it is one of the mechanisms how it produces the problem. With regard to MODS, dysbiosis drives the systemic inflammation, and in relation to C. difficile infection, loss of microbiota is associated with the pathogen bloom. So the main management strategies are to prevent or avoid dysbiosis is antibiotic stewardship, early enteral nutrition, probiotics, selective digestive decontamination, and fecal microbiota transplantation. So with regard to antimicrobial stewardship, the main rationale is to limit microbiome injury. Early enteral nutrition, it helps to preserve mucosal barrier and microbiota. Probiotics helps to restore the balance and helps to decrease the VAP rates. Selective digestive decontamination helps to reduce the pathogens, and fecal microbiota transplantation helps to restore the diversity. So that is the main rationale for all these management strategies. So just an overview, you have an ICU patient, dysbiosis is suspected. Supportive management is antibiotic stewardship and early enteral feeds. Adjunctive is probiotics in selected cases, and selective digestive decontamination only in selected ICUs. This is more important only from a theory perspective. In most of our India ICU settings, this is not a feasible option because of the high resistance rates. And in rescue scenarios or in research phases, fecal microbiota transplantation can be considered in refractory cases. So coming to probiotics in ICU, probiotics are live organisms that when administered in adequate amounts confer a health benefit on the host. So critical illness profoundly alters the gut microbiota due to antibiotic exposure, mechanical ventilation, altered nutrition, and systemic inflammation, like we discussed in gut dysbiosis. So this predisposes to VAP, antibiotic-associated diarrhea, and C. diff infections. So
restoring microbial balance with probiotics has therefore been studied as an adjunct in ICU care.
So the physiological aspects are gut barrier protection. So it helps to strengthen the intestinal, epithelial, tight junctions, and mucosal defense, thereby reducing bacterial translocation. Then the metabolic effects. It helps to generate short-chain fatty acids like butyrate and acetate that support the enterocyte health and systemic metabolism. Colonization resistance. It helps to compete with pathogens for adhesion sites and nutrients, produce organic acids and bacteriocins that inhibit harmful flora. Immunomodulation, that is increase mucosal IgA, modulate cytokine profile that downregulate the harmful cytokines TNF alpha, IL-6, and upregulate the good interleukins, that is IL-10. And with the systemic impact, it helps to reduce endotoxemia, modulate inflammatory signaling pathways. So indications are prevention of VAP, prevention of antibiotic-associated diarrhea, reduction of the candida colonization in gut and oropharynx, enteral feed tolerance, Some trials show a decrease in diarrhea and feeding intolerance. And immune support in sepsis, it is still an investigational area. So when when you have indications, there are always contraindications. So absolute contraindications is severe immunosuppression like neutropenia or hematological malignancies because lactobacillus and Saccharomyces have been associated to cause bacteremia and fungemia respectively. So I put just a reference article over here for your reference. And relative contraindications are disrupted gut mucosa like perforation or uncontrolled fistula, where gut translocation risk is higher if the mucosal integrity is compromised. So probiotics crossing into the bloodstream is being documented in GA surgery and short gut cases. Another important contraindication is in severe pancreatitis. The landmark trial was the Propatria trial. So multi-species probiotics increased mortality and increased the risk of bowel ischemia. So the probiotic strains that were studied are from exam perspective, just concentrate on this column, lactobacillus, bifidobacterium, Saccharomyces, and Streptococcus. So these are the 4 important strains that you need to keep in mind. So coming to the current evidences, there was one study that came by in 2016 by Manzanares where they showed probiotics decreased VAP incidence, even though there was no mortality benefit. In 2020, there was another meta-analysis where it showed to reduce the incidence of VAP, but there was a high heterogeneity which was noted. Based on a Cochrane review, probiotics reduced VAP with a low to moderate certainty. So there was one RCT that was a prospect trial where they had studied lactobacillus versus placebo. There was no significant reduction in VAP, diarrhea, or C. diff or mortality. So that was when there was a concern regards its efficacy in ICU. And from a guideline stance, based on the SCCM guidelines and the ESICM guidelines in 2021, they do not recommend routine use. It may be considered in antibiotic-associated diarrheas. And in the IDSA 2021 for C. difficile, it is not recommended for primary CDA prevention. So these are the current recommended guideline evidences. If at all they ask you to appraise probiotics, I think this slide gives a good amount of information. So another important thing you need to know is about the difference between prebiotic and probiotic. So probiotic, like we had discussed, are live microorganisms that when administered in adequate amounts, confer health benefits to the host. Whereas prebiotics are non-digestible food ingredients that selectively stimulate the growth or activity of beneficial microorganisms already present in the gut. So the nature are probiotics are living organisms, whereas prebiotics are dietary substances like fiber, oligosaccharides, and resistant starches. So the examples, like I said, are lactobacillus, bifidobacterium, Saccharomyces, and Streptococcus thermophilus. So here in prebiotic, you have inulin, fructooligosaccharides, galactooligosaccharides, and resistant starches. So the mechanism for probiotic, they colonize the gut, suppress the pathogens, enhance gut barrier and immune functions. Here in prebiotic, they serve as food for beneficial gut bacteria, increase short-chain fatty acid production, and promote growth of bifidobacteria and lactobacilli, which are present within the gut already. So the clinical role, they have been studied for the prevention of VAP, antibiotic-associated diarrhea, and C. diff prevention. They're used with probiotics to enhance survival and activity in probiotic strains. So they generally stay safe, but they may cause bacteremia or fungemia in immunocompromised patients. So prebiotics are generally safe, but the side effects are usually limited to bloating or gas. So coming to the last question, this is just an add-on, just for benefit for all you guys who are going for the exams. List of trials with relation to nutrition. So with regard to calories and the route and timing of nutrition, we have the EPANIC trial, calories trial, Nutrient 2 trial, Eden trial, and the PERMET trial. So I'm not going into the content of this. This was one PPT I just wanted to put so that you guys could just like use it as a fast reference before the exam. So those who are online, you could just take a snapshot of this. So within 5 seconds, I'll move on to the next slide. So that also you can see. Okay, so the next other few important trials that came up are the target trial, the EAT ICU trial, the Nutria 3 trial, and the intact trial. So mainly made it like a pickup format so that it would be easy to identify and like revise it before your exams. Then coming to immunonutrition and micronutrients. So usually immunonutrition and ICU usually can be asked as a short question. So that is why I thought I should put this table. So this is just one table which shows the basic important trials and the outcomes that were associated with it. So we'll take 5 seconds, then we'll go on to the next one. Okay. So with regard to the protein dose, you have the effort protein trial, which was done in 2023. Intervention was high protein, 2.2 grams per kg per day versus low protein, 1.2. No benefit, but with high proteins, there was a potential harm in AK. So they say to avoid very high proteins. With regard to indirect calorimetry, you have the Tikakos trial. So the one which came in 2011 was a pilot study which showed benefit, whereas the one which came in 2021, it did not show any mortality benefit. So it is used for accuracy, but it has no relation to outcome. So the summary based on this trial is early nutrition, if enteral nutrition if feasible, but don't push to full feeds within the first 48 to 72 hours, especially if the shock is there, because there can be the risk of bowel ischemia. Proteins of 1.3 gram per kg per day is acceptable. Higher doses don't help. PN is safe if EN is not possible, but don't start too early in low risk patients. Avoid immunonutrition. It has not shown to be beneficial. This was the latest trial which came up in 2025. That is the target protein trial. That is augmented enteral protein nutrition during critical illness. So the main population question was in adult patients on enteral nutrition, does augmented enteral protein improve outcomes? So the formula with 100 ml, 100 grams per liter protein, that is an augmented protein group versus standard protein group, that is 63 gram per liter. So there was no improvement in 90-day mortality. So higher enteral protein did not improve outcomes in the general ICU population. So this was the important take home. So this is one thing you need to keep in mind in the latest trials.